This week on the BackTable podcast.
I will tell you, if I were going to give advice to a resident or a medical student who's interested in interventional radiology, wants to find a space that is new and open and ready for innovation and for energy, that's how I started my career with interventional MR. And I've moved on to other things and keep coming back to it because I love it. But if I were giving advice to a young person coming in right now, which is in a very challenging academic environment, this is a place where you can have a huge impact quickly by putting that passion, that energy, that focus to getting these systems up and running and getting them off the ground and being creative in how you apply them to your patients. And that would be my advice. You know, there are a few areas I think can really use a lot of help from our younger generation. But I think if I were starting out, I would be looking at this area with a lot of interest because I think it's wide open for innovation.
Ladies and gentlemen, welcome to the BackTable podcast. If you're a new listener, welcome. For all of our regular listeners, welcome back and thank you for listening. Today, we're going to be discussing, in my opinion, overdue topic for BackTable, MRI-guided interventions. I'm excited to welcome back onto the show Dr. Clifford Weiss from Hopkins and Dr. David Woodrum, interventional radiologist at Mayo Clinic in Rochester. David, Cliff, welcome back to the show.
Thank you.
Thanks for having us.
Of course. It's our pleasure. I always tell the guests, people say, oh, thank you for having us. And, it was a lot of fun coming on the show. But really, the show is nothing without people like you guys to come on and share your experience and expertise. So we really appreciate it. All right. So guest introductions. David, let's start with you. Tell us a little bit about yourself and your practice.
Yeah, so David Woodrum, interventional radiologist at Mayo Clinic in Rochester, Minnesota. Been practicing since 2006. And briefly, throughout my practice, I was very interested in the possibility of what we could do with MR guidance and slowly developed the capabilities and procedures that we were able to go after at Mayo. And so we've gone from doing an occasional procedure in the evenings around 2009 to a full 4 or 5 days a week daytime interventional scanner currently. And so it's been a long process, but we've seen a lot of growth, and it's an exciting time in the field because we see an increasing interest from not only physicians, but also industry. And we see a growing number of compatible equipment, which is expanding our capabilities.
Well said. Cliff, tell us a little bit about yourself for the third time now you've been on the show.
Well, I'll change it up a little bit this time. I'm Bob. Nice to meet you. No, I'm Cliff Weiss, professor of radiology and BME at Johns Hopkins. And my primary focus of my practice at this point is vascular malformations and HHT. I've spoken to you before about our obesity practice and about those two practices as well. But actually, the practice of treating vascular anomalies and interventional MR kind of came together beautifully back in the day. So I came at this initially from a research perspective, which was we wanted to work, and I was working with my mentor, Arvind Arapali, and we wanted to figure out were there procedures we couldn't do right now, and right now is in the early 2000s, that we couldn't do as an interventional radiologist or do it well, we could do better using MR-guided techniques. And so we were doing research into tagged islet cell transplantation into diabetic animals. And we were actually also trying to create interventional mesocaval shunts and do right atrial septal punctures, all with MR guidance. So we really came at this initially from the research perspective. And then as it morphed, the department under the guidance of John Lewin put in a hybrid MR angio suite in our MR research area. And then we started moving patients into that area. And we started with vascular malformations at Johns Hopkins. And then that morphed eventually into MSK interventions, et cetera, with the work of Jan Fritz. So again, we came at it from the very beginning with our MR research group from a research perspective, and then moved those capabilities into patients, which was kind of cool.
And you were telling me a little bit offline, one of the physicians from the country who came to kind of see some of y'all's techniques and learn from you was David?
When I finished my fellowship, I spent two months at Hopkins. And so seeing the interventional techniques that they were researching and developing, and so that helped really give me the springboard of knowledge to start trying to adapt that and bring that back to Mayo.
Virtuous circle. I like that. All right, so let's get into it. And I'll just try and jump right into like the heart of the topic. And one of the questions I have is, what does MRI bring to the table of interventional radiology? And from that, like I have like it's like a two-part question. What are the procedures that, as in, like, give you a background? And I think like this might be cross-sectional of our audience. I don't do any MR-guided interventions, fluoro, ultrasound, CT. And actually, I really don't even like CT. If I can just do ultrasound and fluoro, that's the goal. So there are two things. What procedures can I be doing better? But like the first question I want to ask is, what are the procedures I'm just completely missing out on by not using MRI?
So can we go back one step?
Yeah, let's do it.
And I'm going to ask you, why do you not like CT? I know I don't like CT. Why don't you like CT?
The spatial resolution is not great. There's a temporal disconnect. The way I use CT is I won't actually do live CT fluoro. It's always like a step and shoot, move the needle, move my hand, step, take the picture and then go in. And it's kind of inchworming along. And then even once I get to do something like, say, an ablation, a lot of times you're triangulating. If you don't see the lesion well, you're triangulating things based on, any kind of anatomic landmarks. And ultrasound gives me that it's like live. If I can see it well, I can hit it well. And so maybe it's a combination of temporal and spatial resolution that I'm lacking.
How do you like working purely in the axial plane?
Exactly. Also not great. Actually,
so you just answered why interventional MR in your own answer. So I'll start with the why, and I'll let David take over the procedures that we do, because to be fair, he's probably the most prolific practitioner in the country. But the reason we've said YMR for years is all those reasons, right? You're not exposing yourself, the patient, or the room staff to ionizing radiation, including your young and potentially women of childbearing age and your pediatric patients. You can look at things in multiplanar ways and pick whatever approach you want, like ultrasound, and you can see your anatomy with exquisite detail, and you can change the imaging to ramp up temporal resolution, ramp up spatial resolution, and change your weighting to see whatever you want to see, whether it's vasculature or surrounding soft tissue structures. And so you have all of that built into one. And then I will also say, ultrasound a little bit aside, but when you use CT or use angiography or X-ray, you're really taking pictures, right? In ultrasound, other than a little bit of maybe looking at elastography or looking at flow, you're also taking pictures. But when you're doing MRI, you're having a conversation with the patient. You as the physician and with the technologist behind you are asking the machine to ask questions, and then the patient's answering those back to you, right? And so you can ask whatever question you want. If you ask it the right way, you can get the responses you need to have the best efficacy possible. And on top of that, you can do temperature mapping. And on top of that, you can go in and out technique or real-time technique. So lots of flexibility and power to the MR scanner. And I'll turn it over to David from here and let him say something.
So completely 100% agree. I think I love the analogy there that you presented, Cliff, of the MR having a conversation with the patient, because it really kind of gets at the fact that with the MR, we're not stuck in just looking at it in a single way. We can tailor what we're trying to see depending on how we tune the magnet and how we tune the sequence. And so I think that's a hugely powerful, because number one, as an interventionalist, as you were just pointing out up front, if you can see it, then you can target it. And if you can see what's happening as you're treating, then you can make sure that you're getting a good result. Okay? So it's when we have lapses of, well, we kind of see it, but we kind of don't, that our targeting may not be quite optimal. And then if we can't see what's going on while it's happening, like during an ablation, how are we supposed to get a perfect result if we can't see perfectly what's going on? And so that's the solution that the MR offers. And so to that, we see a plethora of procedures, especially in the pelvis. Pelvis is a weak point for CT imaging. Pelvis is a weak point for ultrasound imaging, but MR excels in the pelvis. So as such, we see a ton of prostate related procedures. So early prostate cancer, late prostate cancer, where it comes back after surgery, after radiation, or after both. We can very precisely target and treat those recurrences, whether it's with focused ultrasound, whether it's with cryoablation, or even laser is a possibility down there. And so we see a huge spectrum of procedures in the pelvis around prostate, but also oligometastatic disease. We also see for women, especially those women that may have gone through pelvic exonerations and they have a small recurrence that's caught on PET scan. Afterwards, we can target that. We can go after that. And so really the pelvis is a very strong point for the MR. But then as we move up into the abdomen, we look at the liver. We're now seeing a change in how our oncologists and our neuroendocrine docs are looking at disease in the liver, because what we're finding is, okay, how do you look at the liver disease? Well, you check it with an MR. You find a 3 millimeter spot in a patient that has a history of having cancer in the metastatic to the liver. That's more than likely going to be, if you have a new spot, that's more than likely going to be cancer. Well, we can go after that 3 millimeter, 5 millimeter spot, and we can either try to biopsy or we can biopsy and treat that disease. And so what we're seeing in the liver is that we're tending to go after the smaller lesions and do it on a more aggressive timetable. So we're not having to wait till it gets big enough for us to see it. We can target it as soon as we see it. And that's really powerful for trying to jump ahead of this disease. And so we're seeing that's where the strengths of the MR. The other thing that, to Cliff's point about the vascular malformations, we're now able to treat some of these vascular malformations that are in the foot or in the hand that really were off limits before because we just didn't have the resolution with CT to see the edge of the ablation zone well enough to know we're okay.
To add to that component, David, right? If you think about the fact, and we talked about this, I think Aaron and I talked about this in the last podcast about vascular malformations, MRI is the gold standard for diagnosis and tracking. So we take the gold standard, and then for me, I put them on my table, and I take an ultrasound and treat based on gold standard imaging, right? So why not just treat with gold standard? So our initial population at Hopkins we treated with were patients with difficult to treat vascular malformations that were maybe behind the scapula or had been treated 2 or 3 times, or too small to see with ultrasound. And we could treat them very effectively using MR. And we would do a sclerotherapy. Now I would use bleomycin because it's safe even if it's outside the lesion. But you can also, as David will attest, you can do laser ablation, cryoablation, and really mop up these lesions in a different way. And so for that, you really do need advanced imaging like MR, right? Why would I have this wonderful T2-weighted sequence that I can see everything and then switch to ultrasound where I can do it 90% of the time, but an average practitioner may not know what they're looking at? That's kind of crazy.
Sure. So one of the things I heard you say, David, is whenever you're choosing to use an MR intervention, one of the things you said was targeting. You can target smaller lesions that are maybe too difficult to see. But one of the things I wanted to dive into a little bit was, I guess maybe it would fall under like the monitoring category. Like if you're doing an ablation, you can pick microwave or cryo, how does that look when you're doing an MR-guided ablation? Like, are you able to kind of talk me through like how you're seeing the ablation zone and how that changes things?
So there's a specialized MR sequence that we can use to see tissue heating. And so we can see the tissue heat up and move out as the ablation zone expands. And so we're seeing exactly where we're treating, and we're getting that feedback. So we know when we've covered the margins. We know when we're encroaching on something we don't want to hit. And so that's extremely powerful. And we can do that through multiple slices so that we get actually a volumetric view of that through multiple slices. Now, on the flip side, with the cryoablation right now we can see exquisitely well where the ice edge is. So if you're treating in the pelvis where your imaging is degraded by CT, or even in bone where sometimes it's really hard to see where the ice edge is, you see that exquisitely well. And you see that into a resolution of sub-millimeter type resolution.
Yeah, and And by doing temperature mapping, you can track even the thermoclines so that if you are about, let's say you're treating in the sacrum and you want to avoid a nerve root, that ice ball can jump right through bone. But if you're watching the adjacent nerve root drop in temperature and it starts to drop to a point where you know the ice is about to form, you dial down your ablation. So you can be, and this is not kind of a general temperature map. This is a quantitative temperature map. It tells you what is the relative temperature of that tissue, right? So you can really, really be very precise in what you want to hit and what you don't want to hit, even through structures where typically you would never be able to see ice ball or an ablation like bone.
The other thing that it allows you to do is there's many times where, especially for post-prostatectomy patients, we're treating recurrences that may be in the seminal vesicles. There are times when I will intentionally place a cryoneedle between the nodule and the ureter and have that needle on warm as I freeze the other needles towards it. And I can see the ice edge well enough to know that I'm not getting into the ureter. And it may be millimeters of distance there. And so you can actually watch that in real time and control it well enough to know, okay, I need to thaw to kind of prevent the ice from encroaching on the ureter or on a nerve. I mean, those kind of things you just don't see well enough in CT to really make that a feasible technique. In MR, you're seeing well enough to do that.
So one of my other, so I hate to take it from the elegant solution that you just used with prostate, because like that's not something I do. So it's hard for me to, like, so what I'm trying to do is make it more relatable. So say like we're going back to the liver and you're ablating a lesion in the liver and you can see the ablation zone, you see it's not covering the lesion. There's a lot of architectural changes whenever you're doing a microwave ablation. Like, what's the downside there? Like, is it as simple as you say, I guess is what I'm saying. Like, is it as simple as like, oh, I can still see the lesion and I can see my ablation zone and these two things are very clear and easily discernible?
It is. Now, technically, putting it all together is still a little bit more difficult than it is on the CT.
Okay.
And so the technicality of getting everything to work in a seamless manner is what is exciting about the future, because we now have industry that is very interested in this area. And we're, both Cliff and I, are working to help them realize the clinical scenarios that we need to facilitate. And so that we make it easy for our IR colleagues to get in this, because historically it hasn't been easy. And so that's part of the excitement that's currently, is that the field is moving towards an easier solution. Now, one thing I will point out in the liver is, let's say I've had a situation recently where there was a liver met that was sitting in the left lobe, top of the left lobe, right up underneath the heart. Okay. I could put cryoneedles up into that and I could see exactly where the ice edge was next to the pericardium of the heart. Now, that's not something you would do necessarily with microwave because of the possible, cross reactivity into the heart, but it's a situation where the precision of imaging, you can use that, cryo to really cut a very tight edge there and to see that you are indeed not freezing into the heart, which is kind of a concern.
So Chris, though, I definitely want to talk about what the future is and overcoming that barrier to adoption. But you did ask an earlier question, which is, what are we not thinking of that we could be doing under MR guidance?
Right.
And I think with the appropriate equipment being developed, and I think we can talk about these integrated rooms in a minute, there are a host of endovascular procedures that we could be doing under MR guidance. The kind of the lowest barrier to entry, oddly enough, and the best use case scenario is probably TIPS, where you can do a single stick TIPS because you can literally line up your hepatic vein, your portal vein, and push and you're done. It's sort of like using ice, but honestly, it's much simpler than that. But you couldn't do any of this without the room being developed properly and the disposables being developed properly. And so there are other endovascular procedures coming. And so I like to think about it this way. Chris, how many pneumoencephalograms have you done in the last 5 years?
I would say close to or exactly 0.
Yeah, probably in the last 12. And how many double contrast barium enemas has your department done? Probably close to 0,
I
right?
hope so.
But when we trained, maybe pneumoencephalography was gone, but I was doing double contrast upper GIs and BEs for the first year of training. Those have gone by the wayside. So I think interventional radiology is spectacular. We're doing amazing things, minimally invasively. We're really helping patients in our hospital systems. But I think we're going to look back in 20 years and we're going to say, remember back in the day when those interventional radiologists who were so important to medicine, they did these crazy things where they moved catheters around the body, and the only way they could see their anatomy is by injecting nephrotoxic contrast. Oh, and by the way, they did the whole thing directly standing in a radiation beam where they blasted their patient and their room with radiation. And to protect themselves, they wore heavy lead garb that eventually destroyed their necks, their backs, their knees, and their hips, right?
Yeah.
So I think we do a great job. I think we're going to look back in 20 years and say, wow, those were the dark ages of interventional radiology, right? I really do believe that. And one of the reasons why interventional radiology has been so kind of, I guess, a little bit resistant to bring in, interventional MR guidance into the field is it's a very different environment. I mean, David's interventional suite and mine for MR guidance are completely custom. They're completely different. They use different imaging equipment, different peripherals to be able to visualize and talk to each other in the room. And there's never been a plug-and-play system. And right now, industry is working super hard on creating a suite where you order the suite, they bring it in on a dolly, right? Not with a crane, and they drop an interventional, MR-guided intervention suite into place so that you're not, figuring out where the RF leaks are, how you can get the screens in the room, what anesthesia machine can you use, what biopsy devices. And they're developing the peripherals to go with that, all the disposables, all of the audio equipment. All of this has to be thought about in a high magnetic field environment. And so when that is available and they really start training on that magnet, I will tell you, once you do this 1 or 2 times and you're like, wait, I can see everything. I don't have to wear lead. I have all this anatomy and all this ability to customize what I'm seeing in front of me. You don't really want to go back again, right? It's very hard to go back once you have this gold standard of imaging in front of you. And I think in the next 5 years, we're going to see that roll out from industry. And with the help of a whole group of physicians have been calling for this since probably the 90s, right? We're going to see this launch in a meaningful way where trainees are asking to use interventional MR-guided interventions, not kind of being, squeezed into it, right? Right, David and I train people in this, and then they're one of one, right? Or they're one of 4. We're going to be looking at hundreds of people being trained in this when industry catches up.
So the industry catch-up is something that I want to come back to, but it dovetails nicely, Cliff, what you said is what I want to talk about. So I want to focus on the disadvantages of MRI. And so we've talked about the reasons to use MRI, the advantages to using MRI. It all sounds very eloquent. So why is the interventional radiologist out there? Why are most interventional radiologists not using MR guidance if it's fantastic?
It's challenging to put together. And so I think, as Cliff nicely laid out, currently the suites that are out there are custom designed. Now, a little bit to your point, you talk about how much you love ultrasound. We actually have 2 ultrasound machines in our interventional MR suite. But because of the magnetic environment, we actually have these tethered to the wall to make sure that they are safely used in the MR suite and they don't get nudged too close to the magnet to where they would become pulled into the magnetic field. And so we still struggle with not everything in the room is purpose-built. That's what we need. We need more purpose-built solutions so that you have a robust safety margin. But when you have this magnetic field, it adds some technicality on how you bring in equipment and tools that you use. Cliff, I'll hand it off to you.
How do you see things in the room, right? You need a screen that you can see large enough that, those of us who have to wear glasses can't be working on a screen this big. Also, Chris, I can talk to everyone in my angio suite just by talking, right? You can't do that in an MR scanner when you have a banging gradient going on, in the background. It's a loud modality traditionally. So you have to be able to talk to each other. And then how do the headset work when you can't have an RF generated in the room. These are things they've been worked on for years, and they were all completely custom. So that's one barrier. The other is traditionally getting at your patient. You couldn't just reach out and touch your patient. You had to stretch yourself into the magnet, and you had to know how to run the magnet or have someone who was a team member who ran the magnet, because it's not just hit the pedal and you see things, although that actually is something you can do now. Part of the problem was traditionally we've been working at high field, 1.5 Tesla and 3 Tesla. At 1.5 and 3 Tesla, everything's louder, everything's a little more dangerous, can get sucked in the magnet. Everything has to be tethered down. Devices are harder to see and to use because they can heat at those field strengths when the gradients are turned on. And so those high field strengths gave us these wonderful, beautiful pictures and massive technical challenges. And so most interventionalists, we're not the most patient people. We all have a little touch of ADD. And so none of us are going to spend the time, unless it's someone like David and myself and a host, maybe 50, 60 other groups in the world, to really solve those problems and go do them. Once you've done it, it's very straightforward to do it. And then when something breaks, how do you problem solve, right? So that just was beyond kind of the, get things moving, get my patient on and off the table, very rational clinical mentality of interventionalists. The newer systems are coming out at low field strength, so they're not as expensive. You're also not burning diagnostic magnet time in such volumes that your chair goes crazy, right? And the peripherals have now been worked out to the point by a secondary company. I shouldn't say a secondary company, a second company working in partnership with the first, that they know what goes in the room, how it gets installed, how do you shield it. It's all been built so that David and I can both put the same suite in. I can walk into his room, he can walk into my room, and they look exactly the same. And because they're at low field strength, adapting current technologies to work in that field strength, whether it's audio or visual or disposables, is much, much easier and a much lower barrier to entry. And low field strength traditionally has been really, really poor imaging. But with kind of real-time AI overlay, you can really make that imaging 1.5T quality or better. And so we're coming to this point where the imaging technology and the table technology and the peripheral technologies are now being integrated, and it can work together to really make a suite that any interventionalist could be comfortable using. And that's industry's goal right now. And that's really, really exciting for us.
But I'll put the question out to David and Cliff. Like, how far away is this? Like this suite that somebody can order and it comes into your system. It's a plug and play system to where you don't have to invent MRI protocols. Maybe, I'm sure there's some training that goes along with the physician and the technologist, but it's not overly onerous, where maybe, if I had to imagine, David, you have 1 or 2 MRI technologists that you work with and you trust them implicitly, but you can't take the MRI technologist who's scanning knees all day and just bring them in and say, hey, let's ablate this prostate.
Right. I have 5 core technologists. I have 2 super users.
Right.
And so, no, I think we're actually on a time frame that is anywhere from, I think, 1 to 3 years before we can start really plug and play type situation. And Cliff may disagree with me on timing. It's hard to know how these...
I would say 6 months to 3 years. I would bring it down more.
Okay.
Right? I mean, if you're talking about biopsy and needle-guided procedures, we may be 6 to 12 months out from system installs somewhere, as the launch is going to be occurring any day now, from what I've been told. But I think before you have a cadre of people that are really excited and want to do this beyond the 100 users in the world that are really doing this. And I think it's about 100 clinicians, maybe a couple hundred. Our last meeting was pretty robust, our interventional MR symposium. But I think when you have a kind of a gaggle of trainees coming out who say, we want this, you're talking about 3 years. We're not talking 10, 15 years anymore. You're talking, well within the next 6 months to 3 years, really. Yeah.
So one of the things that seems exciting to me, like one of the use cases, is if I was thinking about like biopsying something, and you're talking about like, David, you mentioned like a 3 millimeter lesion in the liver. And if I'm thinking about having to do that on CT, extremely, extremely difficult with something that's moving. Is it a possibility if you're doing that with MRI guidance? Like, I mean, the MRI magnets that I'm thinking like I have to have like an arm that's like 6 feet long to be able to reach into a magnet and advance it under lifetime. Is that a possibility with these new systems, or even the system that you have? Like you're moving the needle as you're taking the picture. Oh, sorry, go ahead, David.
You can. I would have to say in our current setup, we're on a 1 point. The live imaging becomes more facilitated by low field, to be honest. Our current system is a 1.5. And for something that we're trying to hit like a 2-3 millimeter lesion, which actually we did for a young lady because she had a history of ocular melanoma and a 3 millimeter spot showed up in her liver. And the question was, is it a MET? Okay. Couldn't see it by any other modality. It was really agonizing for her. And they finally reached out to us in MR, and we were able to target that and get a sure answer. The problem with CT and ultrasound in that situation, if you get a negative result, are you confident? No. With the MR,
you can show people the needle through target with MR.
Right, exactly. And so you have that picture where the needle's going through this tiny lesion, and you're like, I'm there. There's no question.
So even like, let's talk about like the rooms of the future, the hybrid rooms that are set up with a low field magnet and that have all the peripherals set up. A lot of the bugs have been worked out. There's got to be a trade-off when you're talking about MRI. I mean, like anytime I'm thinking about like CT, fluoro, ultrasound, there's always a trade-off between spatial resolution, temporal resolution. We've talked a lot about the good things about MRI, but what are really some of the limitations where you don't like MRI or that frustrate you about MRI?
So Chris, I think the nice part about this is that, I would argue with you that you're 100% correct, right? If you had to think about a magnet that was ideally situated for interventional MR, you'd have a dial on the left, which was speed versus resolution, and a dial on the right, which was T1 versus T2. And you would, you'd work in a button factory and you'd turn the buttons and make it work. But that's really true. Let's go with the hardest case scenario. So let's do an endovascular procedure. I don't need great spatial resolution to go from iliac to liver through the aorta. I'm pushing a catheter. I need temporal resolution. But now when I'm going to traverse from celiac axis to a peripheral right arterial structure, then I need spatial resolution. And so the beauty is you can dial it up and down. The challenge is you have to know when to dial it up and down. And really, you need to still have a teammate outside the room that knows what you're trying to do and can help you get there, a technologist. And here's the other reason. MR is great at planar imaging, right? Multiplanar imaging, but it's still a slice. And so you have to realize that the body's three-dimensional, and you have to play with that to make it more volumetric or to be able to track your device slice by slice, all of which can be done. But those are the inherent imaging challenges, all right? And at lower field, easier to go fast, harder to get high resolution images, right? But you can reach into the magnet much more easily with the current magnet design. So you can, in real time, even with little short arms like mine, get them into the magnet and stick a needle to target using the newest low field systems that are being developed, because the bores are wider and the distance to isocenter, which is where you really want to be doing most of your best imaging, or just off isocenter, a little closer to you, is much shorter than it used to be. And so you used to have Eddie the Eagle arms to get in there. And we had a practitioner named Frank Walker who was like 6'3" and would, swoop into the room and then I'd be crawling in with the patient to get in there. And you don't have to do that anymore, right? There are pictures of me like on top of my patient trying to put the needle in the magnet. That's gone now, right? And so I think those are the difficulties. One is patient access. One is knowing how to get your imaging teed up so that you can get pseudo-volumetric or pseudo-projection imaging, or at least track your device through planes, all of which is now very capable and very possible.
Okay. David,
what do you think are the hard parts?
I think that the upcoming magnet configurations are very exciting about the possibility opening additional access to the patient. And I think that's going to change the landscape on how we do these procedures. I think the current landscape of current magnet configurations lends itself more to kind of that move and image. It's so stepwise, kind of like what you were talking about with the CT. And so I think if we can move to live imaging, that's going to offer a really significant jump in how we do it and the speed. Now, for us too, what we've noticed is that really for our procedures that we do in the MRI versus CT, really we're getting the actual, like for ablations, we're getting the ablations done in the same time frame. Really, the only difference we're seeing is typically in the MR, we take added time to do further diagnostic and localizing imaging up front. And that really is where we see the difference in the timing. Because with CT, you just scan real quick, and that's your plan image. Well, with MR, we tend to want to get, okay, let's get a T2 image, maybe with FATSAT, maybe a balanced FSC that's balancing between T1, T2, but all those take a little time to get diagnostic quality images. And so that's what we're really left with seeing as far as differences in timing for like an ablation. If you control for size and number of nodules in the liver that you're trying to ablate, really we see very similar ablation times between CT and MR now. And so, you can hone this. Now, this is done with a MR crew that's familiar with procedures. So we're not doing this for the first time. They've done this 100 times. And so, you need that familiarity, but there's no reason you can't be on a similar timetable for these procedures as we are with other imaging modalities.
And interestingly enough, David, I don't know what you found, but we have found it much easier to train MR techs to do procedures than it is to train IR techs to run the MR scanner appropriately.
Oh,
now,
yeah, 100%.
As we switch to vascular procedures, and for me, the holy grail for me is vascular. That's something I'm very excited about. I love needle guidance. We've been doing it for years. I really want to do vascular. As soon as we move to endovenous and endovascular procedures in general, we're going to need to bring more of the IR tech into the room. And so that'll be an interesting kind of cross-training as well, where you have an in-room procedural technologist, as you would anyway, plus the outside of the room MR technologist.
Yeah.
But people are very excited. When they first get started, they're a little frightened. But when they really start to see what they can do, it's an interesting and fun experience for the technologists and the nursing staff as well. So I guess, training eventually will be interesting. I know the companies that are making these magnets and making the peripherals and making the disposables have educational programs in the pipeline to both train the technologists, the nurses, and the physicians. So rather than this sitting where it has for 30 years in the hands of big imaging companies, which are great at making 10-year plans and giant pieces of equipment with some training that goes with them, we now have device companies that are involved, or device company that is involved, that really understands how to make the end user comfortable. And I think that combination of education and usability in combination with an imaging system that really works for this and is tailor-made for this program, right, for this concept, that's going to really make this work. But for years, it's lived in the hands of Siemens, GE, Philips, kind of less so Canon and Toshiba, really, and those three vendors. And they were great at making equipment that we needed. They weren't so great at figuring out how to make it usable for the every interventionalist. And I think that's where the device companies can really, really lend a hand and are actively doing so right now.
So it's funny, like as you're talking about like you're saying, oh, needle localization is very cool, Cliff, but your heart is in like to see like being able to have like endovascular capabilities. To me, like as you're talking about that seems so far away. I mean, but that's only because I'm not using MRI for anything. In this scenario, is it like the way you envision it? Is it MRI exclusively or MRI suite with fluoro? Like sometimes there's a fluoro CT suite.
We have a fluoro MR suite, and we have the old interventional magnet called an Esprit by Siemens, which was a great interventional magnet, which is an end of life right now. It was short bore, it was wide bore, and we could fuse images in line with a transfer table. And we still pretty much use it for percutaneous intervention, not for endovascular. If I think we're 6 months to 3 years away from percutaneous intervention, biopsy, sclerotherapy, ablation, we are 3 to 6 years away, or 3 to 7 years away from a widespread use of endovascular intervention, and probably 3 years from a kind of constitutive launch where the high-end users are able to do it. There's just more stuff. You need to have wires and catheters, but we're not as far as we were 10 years ago. I've seen the disposables having been designed to work, or at least plans for those. So I think any imaging company and any device company is going to start with the lower hanging fruit, which is mostly needle-based procedures. And I would put tips in there, believe it or not, because it's such a good use case scenario. But after that will be vascular.
David?
I would 100% agree. And to that point, to Cliff's point, we are currently able in our current MR suite to use a disposable cystoscope and actually do in-room ureteral stent placement with a cystoscope over the wire. We're not as far as it seems. This is all coming down very rapidly. And so I think we're just at the beginning of an exponential curve going up as far as what we can do, where we can do it.
Well, so the big change, like the big sea change, at least from just talking to you guys, like what it sounds like is this new collaboration between an MRI company and a device company to create like a whole suite of solutions that makes a MRI interventional suite feel like an angio suite. Is that the sea change that's going to take place?
Yeah. With the devices you need to see and hear and do, and then the end actuators to actually get the procedures done, combined and integrated with the imaging system. That's what we're seeing. I will tell you, if I were going to give advice to a resident or a medical student who's interested in interventional radiology, wants to find a space that is new and open and ready for innovation and for energy. That's how I started my career with interventional MR, and I've moved on to other things and keep coming back to it because I love it. But if I were giving advice to a young person coming in right now, which is in a very challenging academic environment, this is a place where you can have a huge impact quickly by putting that passion, that energy, that focus to getting these systems up and running and getting them off the ground and being creative in how you apply them to your patients. And that would be my advice. You know, there are a few areas I think can really use a lot of help from our younger generation. But I think if I were starting out, I would be looking at this area with a lot of interest because I think it's wide open for innovation.
Echo that sentiment, David?
100% agree. 100%. I mean, there's so much to be done. Many of the hurdles that were daunting before have been basically broken down. And so with the interest of the corporations and industry, the tools are there. It's a matter of getting them put together. And very soon, even that piece is going to be much simpler. So if you're coming out, you're going to a hospital and you say, hey, I want to bring to you a unique treatment option. That's huge.
So so now I'm going to pose a question very concretely. So you have a young attending, fresh out, just graduated fellowship, has not done a single MRI-guided intervention. What's the next step? Like, do I have to
us?
Yes.
That's what
yes. No, seriously.
Yeah, okay.
They got to come trained. So right now, the answer is send them to one of the centers, whether it's David or it's me or it's someone in Europe or it's someone in wherever they're doing it, because they got to get comfortable in the environment. And then they need to go out and spend some time with the companies that are doing this, because that's the equipment that they're going to want to bring in. I mean, David's been super successful in generating clinicians who do this for a living, right? I mean,
yeah.
David, you know more about this than I do at this point.
Yeah. So, I mean, you need time to see. I mean, it's not that the procedures are so different than what we do with CT or fluoro. It's just there are additional parameters that you have to keep in mind. You have to realize what's safe to bring in, what's not safe to bring in. How can I safely bring this in? And that's why we've incorporated the ultrasound into the room, because we think it's an important piece to get that initial skin puncture or whatnot. And so they need to see how it's orchestrated in a real-time fashion. And what I typically advise for people that are interested in getting in, come see what we're doing for a day or two. Go back home, talk to your people there, start getting a team kind of lined up, and then come back with the team so that your technologist can sit down at the console with my technologist, see what they're doing. Your nurse can talk to my nurse. And, you know, as a clinician, when you come back the second time, you're picking up different details than you picked up the first time. And so there's a few more details than there were with just doing, a CT or fluoro procedure. Plus, you're very familiar with those. So we need to educate you on the additional concerns the MR brings into it. Now, as Cliff nicely pointed out earlier, with the low field, these safety concerns decrease exponentially. I mean, they're an order of magnitude less with the low field than they are with 1.5 or 3T. And so they're going to make it even easier to do all this. And that's why we both think that this is on the verge of an explosive horizon, because this low field merging of technology with purpose-built tools, hey, it's going to take off.
It's almost impossible, I think, for it not to take off, because truly, once you do this for the first time and beyond the diagnostic component, you see how easy it is to do this. And you're not wearing lead, and your patient is happy, and the referring physicians are happy. It's hard not to keep doing it. But another thing that I know that David has done extraordinarily well is he can teach, we in general, but I know David does a lot of this. You have to be able to have the economic conversations with your hospital. You have to have the marketing conversations with your department and be able to tell your referring physicians why they want this in particular, right? Why they don't want to just order a biopsy. They want to order an MR-guided biopsy with Dr. Woodrum or Dr. Weiss, right?
Yes.
Or Erica or any of the people you've trained out there who are now doing this, right?
Right.
And so that's important too. I also would tell a junior faculty, and so I think when we started, we were very involved with the industry from the beginning because you needed to get these equipment and up online and be able to use them. But a lot of junior faculty are a little uncomfortable sometimes engaging with industry in an open and meaningful way. Industry, and I say this now, this is a little soapbox. With the way federal funding is going right now, industry is going to be leading the way in a lot of biomedical research. It's getting comfortable on that conversation on how to talk to industry. It's super important. In this field in particular, having your industrial partners help you set up your system, figure out how to market it, give you backup and support when you need it, right? That's all super important. And so a really collaborative, open industrial partnership, you can't underestimate that right now. And making sure that door is open to anyone who might be building the tools and equipment or providing the training you might need is also important. So it's the clinical training, it's the marketing, it's the economics, it's the PR, and it's also how do you work, comfortably and openly with industry so that we can really build these systems out and make it safe for patients. You did your first 10 thrombectomy cases, your rep was probably standing right there, right? You did your first 10 MR-guided biopsies, you're going to need someone standing with you to make you comfortable. And that's okay. That's actually not only acceptable, it's really important to do because they get better as industry when we get better, and we get better when they get better. In this field in particular, it's not just your talent and your skill, it's your understanding and use of the technology.
Yeah, very well said.
Speaking of the economics, and David, I'll put this question to you.
Yeah.
Reimbursement for MR-guided interventions, problematic or go ahead?
You have to look at it. The reimbursement for many of these procedures is going to be very similar to your, especially for ablations, it's very similar to your reimbursement for CT-guided ablation. You have a CT guidance fee that you charge with your CT ablations. We have an MR guidance fee that is very well reimbursed and is better reimbursement than it is with CT. But beyond that, there are specialized procedures like prostate ablation where there are specific codes for that. And those codes, you have to look at those and see for some of the codes there, they need ultrasound combined with whatever else you're using with imaging. Well, you need to be able to add that in. And so those are, but you get to utilize those same codes. So it's not like we're pulling codes out of nowhere. We're piggybacking on our standard codes that we're using. And what you then can do is add on an MR guidance fee. Now, the thing that the institutions have to keep in mind is many times when you start offering these, whether it's for vascular malformations or early prostate cancer, you're bringing in new patients to your institution that were not going to be there otherwise. New patients into the institution are very profitable. And, most institutions are tracking very carefully what their new patient look like, percentages and numbers and all that. And so if you are creating a service that is potentially bringing in new patients that wouldn't otherwise be coming to your institution, then that is huge. And we track that on a regular basis so that whenever our administrative team starts to question things, we can show them the numbers. The other numbers that you have to realize is you're doing this because whatever you're doing was best seen by MR. So your follow-ups are all MRs. So every time I see a patient in follow-up, there's an MR. And so it's not that I'm trying, I'm not pulling a fast one. That's just what we need to use to get, And so, but that is also that enhanced imaging is more coming in for the institution.
Okay. Well said.
And the other thing I would say to that, David and Chris, is that, and so let's say you're starting out and you want to make sure you have the right patient. So let's say 4 patients come in for an MR-guided intervention. Only 1 needs to be done under MR. And the other 3, you could do a chemoembo, or you could do another ablation. You've just brought 3 more patients in for standard procedures. So you track that as well, right? So it's sort of like for some of the newer ablative techniques, I'm not going to name them today, we may bring in 10 and only 1 may end up getting that procedure, and 9 others may get standard liver ablation or chemo or Y90. And so look at that downstream revenue as well. And I think that all makes for the economic argument of this.
Yeah.
Beyond that, and even with a low field magnet, they being our diagnostic colleagues are still able to do high quality diagnostic imaging on a low field magnet. So when you're not running interventions, you can run it like a magnet, because with some of the AI overlay and some of the kind of image improvement, you can make a 0.55 T Tesla magnet look like a 1.5 or higher. And that means that you now have a magnet that can, if necessary, backfill with diagnostic imaging. So it's not just sitting there lying fallow for 6 hours a day.
Well, and on top of that, with the 0.55 Tesla, you're going to be able to put more implants and devices into that with less problems and less artifact. And so it actually, for your patients with a lot of spinal hardware, the 0.55 Tesla actually may give you better imaging in some circumstances.
Well said. Interesting point. One of the other things, so circling back, so new faculty, after they've trained with David, after they've gone and seen your shop, Cliff, other resources like conferences or existing publications that are out there, like what else if they really want to exhaust the boat here?
It's almost as if we had a conversation before this. So there's 2 really good conference resources for this. One is the Interventional MR study group as part of the ISMRM, right? The other is the Interventional MR Symposium, which happens every other year, either in Baltimore, in Boston, or in Leipzig. We just did the 2024 conference in Baltimore, actually in Annapolis. The next one in 26 is going to be in Boston, and I assume it'll go back to Leipzig after that. Those are 2 to 3 day meetings that are interventional MR all day for 2-3 days, and you get incredibly energized. You see all the cutting edge work, and now more than ever, all the major amount of clinical work that's being done at the big clinical shops as well. And so those are great resources. Other great resources are literally giving a phone call to people like David, myself, and the other high-end users around the world who have done this for years. And coming soon to a theater near you will be these kind of hotlines that are going to be developed, I'm sure, by the imaging and device companies that are working to do these. Remember, if you're on many of these systems already, a remote technologist can come onto your system and run it for you. Imagine that's a help desk, or imagine there's a secondary help desk that says, oh, you're trying to do an ablation. You're running into trouble. Let's get Dr. Woodrum on the phone. And Dr. Woodrum jumps online and helps. So right now there are some good conferences. Those 2 I've talked about, the ISMRM study group for interventional MRI, and then the Interventional MR Symposia every other year. Those are great resources. Even if you just want to come and get excited, those are great resources. Yeah. And then things that will be developed over time, I think, by industry and by industry partnership.
100% agree with everything Cliff has laid out there. I think those are fantastic resources. The other thing is that currently it is a relatively small community, and it's a community that everybody wants to help each other succeed. And so whether it's sites in the US or around the world, everyone that I know is open to people coming and seeing what they're doing. And, that's the beauty of such a kind of smaller community, is that we just wanted to succeed. And so there's not the feel of competition so much as, hey, let's help each other move forward with this. There's plenty to be done. There's no need to be competitive about it. It's a matter of let's help each other and do this for the patient so that these procedures are out there for the patients. I mean, because we're seeing, you're opening up potential treatments that are either really hard or not even available for patients otherwise.
Yeah, I double down on that one. Wide open community, tiny community right now, and really excited to help across. There's zero. I send David patients regularly. I send other people patients for things that David doesn't do. We really do send patients back and forth for the specialties that we all practice. But more importantly, we just want to raise the ocean. When we raise the ocean, all the boats rise. And I think even industry, which is, has its own intellectual property and traditionally maybe not as open as academia, is on board with that concept. Everyone just wants to get better and to make the field accessible to patients and to practitioners. So it really is a very warm and open and welcoming community. Another reason why, if I were a young person starting an academic interventional, this would be a place I'd be looking at hard.
All right. Well, very lovely sentiment. I hope that the audience members, I hope you guys heard it. The water's warm with MRI-guided interventions. So Dr. Cliff Weiss, Dr. David Woodrum, thank you guys for coming on the show. Is this a good place to end it?
Yeah.
Yeah, the water's warm, but it doesn't heat uncontrollably while you turn the gradient.
And it doesn't radiate you at the same time.
Don't have that problem.
Right.
To have heating problems with our devices, not so much anymore. But the water is very warm. It's comfortably warm. It's it's like the Blue Lagoon in Iceland. It's warm. It's refreshing. You get a nice drink on the side. It's very nice.
All right. Well said. Guys, thank you for coming on the show. To our audience, thank everyone for listening. If you enjoyed this podcast, and I'm almost positive that you did. In fact, I anticipate there's going to be many, many more MRI-guided intervention podcasts to come, and hopefully so. Please check out the show notes of this episode. Those can be found at www.backtable.com. That wraps things up. We'll see you next time on the BackTable podcast. David, Cliff, thanks for coming on the show again.
Thank you. It's a pleasure being here.
Thank you guys so much for tuning in. If you haven't already, please be sure to subscribe, follow, and rate the show. Let us know how we're doing and what we can do to improve it. We work really hard at making this a valuable resource for you, and we want to continue to do that. So give us your feedback. Lastly, tell a colleague about the show. We think they'll like it. If you have any questions or comments, direct message us at _BackTable on Instagram, LinkedIn, X, TikTok, and Blue Sky. BackTable is hosted and produced by myself, Chris Beck, and co-hosts
Ali Behetti,
Michael Barraza, Sabine Dond, and Aaron Fritz.
Our production team is led by Kieran Gannon,
Aaron Bowles,
Gabe D'Agrazio,
and Josh Spencer.
Design and digital marketing led by Brian Schmitz.
Social media and PR by Ann Dang, Manisha Naganathanahali,
and Manbir Singh Sandhu.
Administrative support provided by Judy Dela Cruz.
Thanks again, and see you next time.